We now move to a critical area in fetal medicine: how to recognize a congenitally infected fetus. Let us welcome Dr. Amarnath Bhide to walk us through the key signs, diagnostics, and clinical approach. Over to you, sir.
Ladies and gentlemen, good morning and very welcome on a Sunday morning. I'm surprised that so many of you are here in the hall on a Sunday morning and listening to me for the fourth time in this conference. Thank you, Dr. Jayakrishnan, for asking me to come to Trivandrum to talk to you all. So my job is to talk about how to recognize a congenitally infected fetus. And when we talk about a congenitally infected fetus, there are quite a few infections that come to mind. But in practice, what we are most bothered about is one virus called the cytomegalovirus. The picture that you see in front of you is Hugo Ribert, who is a pathologist working in Germany. And he observed enlarged cells, and he called them cytomegalia. That's where the word comes from, the name comes from. And he identified this in the year 1881. He thought that this is some parasite of some kind, but it was not until 75 years after he first recognized the presence of it that the actual virus was isolated. And that was because of lots of things needed to happen. Cell cultures needed to come into picture. So it took a very long time for the virus actually to be identified, recognized, and isolated. The scope of my talk today are a few viral infections like cytomegalovirus and parvovirus, varicella infections, toxoplasma, rubella, syphilis, and Zika virus. So don't be worried. I'm not going to talk about each one of them because it's impossible to cover all of these in a matter of 20 minutes. So what I'm going to do is to take you through some of the basics of how does one deal with a situation where we are suspecting congenital infections in the fetus. Now, before we actually talk about infections, we need to know the burden of the disease. And I can't tell you about India. I can only tell you about the country that I work in. And top of the list, as I said to you, is cytomegalovirus. So here you see the prevalence of maternal seropositivity. What does it mean? If somebody is seropositive, they cannot get the infection in pregnancy. They are protected. They've got the antibody. The annual number of infections in pregnancy in the UK is 2,240. And these are a little bit old figures, but it hasn't changed, I don't think, very much. Now, you've got to put this figure into perspective. In the UK, we are dealing with between 650 to 700,000 pregnancies. So we are exposed to, or we encounter about 2,000 pregnancies out of 700,000 pregnancies. It is not common. It's pretty uncommon. That's the first thing to remember. The second thing to remember is a majority of the population, 77, 80%, only one out of five is going to be susceptible to the infection. So remember that in order for the fetus to get infection, there's got to be viremia. Virus has got to be freely circulating in the blood. And that can only happen if the person is not immune or ready. The second infection that we consider is toxoplasma. The seropositivity for toxoplasma is pretty uncommon in the UK, less than 1 in 5. But the number of fetuses that we come across is drastically lower, about 50 out of 700,000, so it's not common at all. Okay. Parvovirus we come across quite regularly. the prevalence of seropositivity is 60-70%. And although the number here I've written here is 940, it is very variable because we get epidemics. We seem to get epidemics every other year. And when there is an epidemic going on, we suddenly start seeing patients in a cluster. And quite a few patients come together at one time. And then once the population gets immunized, there is no more infection for another year. And then another epidemic comes up, and then we see another cluster. So that's how parvovirus works. Varicella. Varicella, large majority of population is immune. 90 to 95% of the population is immune to varicella. And remember, when somebody gets varicella, it is not the infection which affects the baby, but it is the sequelae of the infection. Like healing process causes scarring, and the scarring is what affects the baby. That also, the chances of the fetus getting affected is pretty low, less than 2 to 3%, and also limited to the first 20 weeks of pregnancy. It doesn't happen after that. If anybody gets varicella beyond first 20 weeks, it should be very reassuring. Even if they get it before 20 weeks, generally you should be reassuring because 98% nothing is going to happen. So that's about varicella. Syphilis is really uncommon, and the prevalence of syphilis antibodies, because everybody gets screened in pregnancy, is less than 1%. But remember, having the antibody doesn't protect. So once somebody gets an antibody, they are lifelong, they will be positive. The annual case number is pretty low, 4 in 1,000 is what is predicted, but it's pretty uncommon for me, my practice, to see syphilis in pregnancy now. I'm not saying syphilis antibody positive, but getting a syphilis infection in the fetus is pretty uncommon. Rubella, 95-97% of the population is immune. Now, rubella immunization is recommended as a child, but there is now a new sort of set of thoughts where some people, they decline the vaccination for some reason or the other. And that's why a small proportion of the population is still susceptible. Now, although I've said here number of cases is 1 to 2 in the UK, the last case I saw of rubella was a good 10 years ago. The reason behind that is in order to get rubella, you have got to get it from somebody. There's got to be source of infection. And in my whole career, all the cases that I've seen of rubella have all been acquired overseas. Nobody has got the rubella in UK. The one I saw from Thailand, one I saw from Ukraine. So these are all infections acquired abroad, and that's how they get infected. So rubella is really uncommon in our experience. Lastly, Zika, we don't know. We know that looking for antibody doesn't work very well in Zika. Antibodies are not necessarily protective. And there was a time where everybody was talking about Zika virus. Anybody with little bit smallish head was talking about Zika virus. Anybody who had gone to South America, they were most worried about Zika virus. That seems to have died down. People are not so bothered about Zika virus. Even in South America, people are not talking so much. But we don't know, basically, what is the prevalence. Right. So having armed ourselves with what the prevalence of seropositivity is, then we can talk about what are the clinical scenarios, what are the clinical situations that we come across. So there are 3 types of situations that we come across. One is infection as a possible cause following scan findings. The second scenario is maternal exposure to infections or report of mother having got the infection. And the last one, and the most difficult, positive result of a routinely performed infection screen or torch testing. So we'll go through this one by one. So first of all, infection is a possible cause of ultrasound scan finding. I'm not going to show you ultrasound pictures. It doesn't make sense. What I'm going to discuss is what are the infections what we should be suspecting when we see a particular sign. We see a hydrops fetalis. What should we be thinking of? We should be thinking of parvovirus, rubella, varicella, CMV, toxoplasma. So practically everything can lead to hydrops fetalis. Ventriculomegaly, we are particularly worried about CMV and toxoplasma. When we see a small head, we are worried about CMV, toxoplasma, syphilis, rubella, particular, Zika. All cases of rubella that I've seen were microcephalic, and that's this kind of pathognomonic sign of fetal rubella infection. If we see a small baby, then we should be thinking about CMV, rubella, syphilis, toxoplasma, Zika. But let me qualify my statement here. We don't start thinking about infections in all small babies. So we have got to think about why is this baby small? Can we explain smallness onto something? Is this placental smallness, which is perhaps the commonest reason why babies are small? And the smaller the baby, the more likely that it is not constitutional smallness, there's something else going on. So if we see a small baby without signs of placental insufficiency, really, really small baby, that is when the suspicion should be falling on infection. Because infections are not common, I've shown you, they are pretty uncommon. But if we target our fact finding, case finding to the specific group, we are more likely to hit the target. Placentomegaly, many of these infections lead to large placentas as well, and we see placentomegaly in parvovirus, syphilis, and toxoplasma. Cardiomegaly and hyperdynamic circulations are typically seen in parvovirus and CMV. Calcifications, CMV, syphilis, toxoplasma. Again, I should qualify myself. We are not talking of isolated calcifications. We are kind of putting a jigsaw puzzle together. The pieces must fit with each other. So if we are seeing more and more signs, then we are thinking more in terms of infection. If we see limb deformities, then we are talking of varicella, syphilis, and Zika. So those are the kind of ultrasound features that can lead to a suspicion of infection. The second common clinical scenario, is maternal exposure to infection or maternal infection. And there are two infections which come into the picture: parvovirus and chickenpox or varicella. Because these are obvious. Women report symptoms, they get a rash, and they come to us. Chickenpox is very easy. It's easy to recognize. All the other infections are subclinical. We don't see them because of infection signs. So rubella, CMV, toxoplasma, Zika, we have no signs. These are not the kinds that are reported. So parvovirus and chickenpox are the only ones. Something about serology. How should we interpret serology? So anytime we are querying an infection, we ask for serology. How should we interpret it? We look at IgG and IgM. If IgG and IgM are both negative, then we know the mother is susceptible but not infected. Because when we are doing the test, we are doing it in response to something or the other. If you're seeing an ultrasound sign, do the testing, it's negative, this is not related to infection. Because in order for the infection to lead to ultrasound features, antibody should have come up already. If IgG is negative and IgM is positive, then there is a possibility of acute infection. But remember that IgM is a non-specific antibody, and sometimes it can show up even if there is no infection. So if you follow it up, then IgG will also come up, and that will confirm seroconversion, and that indicates primary infection. If IgG is positive and IgM is negative, then mother is immune and infection is unlikely. But sometimes when we test it, it may be too late for the IgM to be present. IgM might have come and might have gone. So what is generally recommended is to look at the IgG and to find out how how young is the IgG? Has it been recently acquired? And the way to test it is to test how sticky that and IgG antibody is to the antigen. And in technical terms, it's called the avidity. If the avidity is high, it's the mature antibody, it's been present for a long time. That means the mother must have been immune at the beginning of pregnancy, and you can reassure. On the other hand, if it's not very sticky, then this is a young antibody, and that's called a low avidity, and that's what we don't like. That means that mother has recently acquired it, and it's possible that the fetus got it. Lastly, positive IgG and positive IgM. An IgG with low avidity with IgM positivity indicates likely primary infection. So in the UK, when women book for their antenatal screening, antenatal testing, the bloods that are collected are stored. So when we see them later on in pregnancy, we can go back to the stored blood and test them, the booking blood. And that's very, very useful because if we find IgG at the time of testing later on in pregnancy and at booking blood was negative, we have documented seroconversion. And that tells us that the mother has seroconverted. Having said that, if somebody has got the infection, doesn't mean that the baby has got the infection. Yeah? The chances of the baby getting infected varies somewhere in the range of 30 to 40%, more or less. It of course differs a little bit from infection to infection, but that's the ballpark figure. The earlier in pregnancy somebody gets infected, the worse it is because the more immature the baby's immune system is. And also, even if the baby's got infected, does not mean that the baby's got damage. So you've got to demonstrate the baby is not only infected, but the baby has got affection or damage, and we've got to demonstrate that. Lastly, positive test or positive result of a routinely performing infection screen. So in general, performing torch tests without a clear indication is not a good idea because all that you will get is a lot of headache. The test detects antibody but is unable to distinguish between a recent and a past infection. Majority of the positive tests are likely because of past infection, which usually indicates immunity. It's a good result to have an IgG positivity. So diagnostic steps are, first of all, determine if the mother is susceptible, and that is by looking at IgG. Second, confirm maternal infection or seroconversion. If that has not occurred, baby cannot get infected. And lastly, identify fetal infection, and that sometimes may need an amniocentesis to document that. Because even if the mother is seroconverted, for example, for cytomegalovirus, doesn't mean the baby has got the infection, and an amniocentesis will show that. Lastly, assess the impact of fetal infection. So even if you demonstrate that fetus has got infection, you've got to find out whether or not the baby has got sequelae because of that. So clear communication is really important, and I can't stress the importance of communication more than that. So thank you very much for giving me patient hearing.
Thank you, Dr. Amarnath Bhide. Requesting you to kindly take your seat on the dais, sir. We'll be having a discussion. May I also